In this portion of our ethics presentation, we'd like to focus on patient communication. As I've said many times, my favorite quote is, "In theory, theory and reality are the same. In reality, they are not." And what we're looking at here is we have the ideal of ethics and the virtue and the goodwill. But what really happens? What is the realistic back and forth between the patient and the hospital and medical imaging? All medical imaging exams start with the request. And actually, this is where we have a lot of ethical problems to begin with. First of all, did we get the demographics correct? Are we doing the right patient? The next thing we have to take a look at is, what did we really have in the request? How many times have you gotten a request for X-ray for pain or something so ridiculous you had no idea of why you're doing the X-ray? Or what about when the patient comes down and you're doing, say, a trauma series and you're looking at a obviously mangled left hand and the X-ray request says right hand? Is it ethical to go ahead and just change the request and put right hand? Or should we go back to ER and ask them, what is the real request for? This is often a bone of contention because in ER they made a mistake, but they don't want to take the time to redo the request. So again, we get a lot of ethical questions just in the very beginning before we even see the patient. What are the ethical challenges in communicating with the patient? We often think first about language and how many times we have patients that have English as a second language or do not speak English at all. And as a rule, most of us are basically just English speakers. Not that many people are poly or bilingual. What if the patient can't speak at all? What if they're deaf? Or what if they use sign language to communicate? Again, communication to find out what we're doing, why we're doing it, how we're doing it, what the patient's input is, and if they understand what we are trying to communicate to them is important. And again, this is before we even begin the exam. Just to use the medical equipment, we have to make a lot of ethical decisions. Not all patients are totally mobile or young. And if they're young, they may be too young and probably need to be restrained. Of course, you can't restrain them because that would be what? That would be false imprisonment. So we do what we call positioning aids. Anyway, those are just some of the ethical things you look at. And then you look at the idea of, how am I going to use my imaging modality to optimize the exam? If we're doing a 2D projection radiograph, remember, as long as the image receptor, the part, and the primary beam are aligned correctly, we can take the exam in almost any position for the patient. That brings up another thing. What about patients and their stability? Are you going to get a 90-year-old feeble patient on the table and try to do a intercondyloidal fossa image, the old Humboldt's position where they're on all fours, or are you going to modify the exam to be able to do it comfortably? These again are a lot of ethical decisions that you make, and usually we make these very rapidly. One of the big differences between the old film screen process we used to use and digital imaging is that we can do post-processing of digital images. We can actually take the data and modify it to better visualize the areas of interest. We're going to have a whole presentation on this in ethics coming up. But for now, how ethical is post-processing of the digital image? Not all images are textbook. Not all images are perfect. We have to decide that the image is a reflection of the patient's condition at that moment in time. How are we going to best demonstrate the information that the physician needs? This may be something simple, like we need them to lie in a decubitus position for at least 10 minutes to let air rise and fluids fall before we do the examination, or something as complex as trying to position trauma patients. Now we take a look at the skill level that is documented for the operator of the equipment. What am I talking about here? We have some states that have licenses and certifications. We have some states that have certification only. And what is the difference between the different certifications? Because a certification can be for, say in Texas, a non-certified medical imaging specialist or a certified medical radiologic technologist. There are different levels. Limited license. What does this mean for our skill level? And who actually is in charge of documenting the skill level? Well, when we have a certificate, remember, a certificate is an agency that is certifying your voluntary presentation of your credentials, and they are certifying that you are skilled enough to do the exam. On the other hand, when we talk about licensure, licensure is a federal government or any type of government regulatory system that you have to meet certain standards to be able to do whatever the license says you can do. And now we look at what are the types of licenses available. So you can see, just in finding the skill level of the individuals to perform the exam, there is a variety of ethical questions that fall into the realm of what is ethical for doing medical imaging for these patients. Healthcare licenses and certificates are two distinct things. Though the term certification may sound and feel like it's describing a government or state's approval to practice the medical profession, that's actually not the case. When we have a certification, what are the legal ramifications of a certification? Remember, it's a non-governmental certification. My mother could certify that I'm really a good person. Does it mean that I am? Not necessarily. Whereas if I have a license, I have to meet certain criteria to be able to hold that license. A license is a limited time permission that a government entity grants to practice in healthcare. It's given only after verifying that the individual meets certain standards and predetermined criteria, such as education, examination, and experience. So we're not only talking about your education and the ability to pass a test, we also have to have documented clinical experience that demonstrates that you are able to perform the test. Professional medical associations, such as the American Registry of Radiologic Technologists, don't have the authority to grant a medical license. However, they can play a pivotal role in helping an individual obtain a license by advocating on your behalf for a state license. Remember, certifications are provided by organizations and are voluntary. To get a certification, an individual must fulfill all the eligibility requirements specified by that organization. They should also undergo and qualify an assessment, written or oral examination of skills and knowledge. If you could look back many years, we used to have more than one certifying entity for medical imaging in the United States, other than just the American Registry of Radiologic Technologists. And today we have multiple MRI certification entities as well. So getting a certificate is voluntary, as they only need to add to the individual's qualifications, but they don't allow them to start to practice a job or skill. To maintain the certification for a long time, individuals are usually required to undergo continuing medical education, and periodic retests and participate in regular training. The American Registry of Radiologic Technologists does not have a blanket license for all medical imaging. Rather, they have different categories of skill that they certify that you are qualified to perform. In some states, you must obtain a state license before you can work as a radiologic technologist there. That differs from the ARRT certification and registration. If you want to become certified and registered with the ARRT, you must meet our requirements and apply to the ARRT. If you want to obtain a state license, you must meet the individual state's requirements and apply directly to the state. Remember, there are other organizations for ultrasound, nuclear medicine, MRI that also certify you for a job or skill. More than 75% of states have licensing laws covering the practice of radiological technology, although each of those differ from state to state. You must obtain a state license before you can work as a radiological technologist in these states. In addition, many states use the ARRT exam scores and/or credentials when making licensing decisions. In other words, some but not all states require you to be certified and registered through the ARRT before you can obtain a state license. Keep in mind that earning an ARRT credential doesn't necessarily mean you're eligible to work in a particular state. You'll need to meet the state requirements. Again, there is a difference between licensure and certification. About ethics, again, there are certain tenets in ethics that are universal, but they vary from geographical region to geographical region and from culture to culture. So when we talk about medical duties overall, we're looking at care, respect for life, beneficence, or doing good, non-malfeasance, or doing no harm, justice, confidentiality, trustworthiness, and informed consent. Legally, these duties may vary from state to state and from country to country. We look at the Hippocratic Oath as the basis for providing medical care. And we have different medical ethical codes, and each one of the medical healthcare practices has their own ethical code, such as the code for radiologists differs than the code for radiologic technologists, or the code for surgery differs from the code for surgical nurses. Ethical protocols and standards can not only vary from state to state or country to country, they can actually vary from facility to facility. Remember, even your professional responsibilities and job descriptions are part of your ethical duties that you're undertaking when you get a career in healthcare. The takeaway from this is there is no hard, in stone, basic rules for ethics. We only have different criteria that we try to follow, or different philosophies that we try to follow. And these philosophies can be impacted by the culture in which we are practicing our medicine. There's a big difference between practicing medicine in the West and in the East. There's a big difference in practicing medicine in a rural community and in an urban community. So all the ethical situations we encounter vary from moment to moment. Every profession has its own set of rules and regulations, and adherence to them depends on the ethical sense of people in that profession. And sometimes the rules change to reflect society's current status or to reflect the evolution of the practice of medicine. Ethical implications are more significant in some professions, like in the healthcare field, where lives are actually at stake based upon our ethical decisions. Some of the things that we look at today are ethical decisions about child care, euthanasia, medications. All of these things are decisions that we're making currently, and we use the ethical standards that we currently have to make our decision. The medical community should come together for agreement about the ethical practices of healthcare. This includes medical imaging services. Medical imaging services make up only a portion of the healthcare services that are provided. Medical imaging has an impact upon all patients, but is often overlooked as it pertains to patient care. As image acquisition times are short and rather anonymous, and the patient rarely interacts with the interpreting physician, medical imaging is not seen as a medical practice. It is merely seen as an ancillary service. Here we'll review a little bit of the workforce issues in medical imaging that impact on ethics. Medical imaging has its own culture within the healthcare, and we must be aware of the holistic healthcare culture and differences in the cultures of our coworkers and patients to optimize patient care. What are we saying here? We're saying healthcare has its own culture, nursing has its own culture, surgery has its own culture. Each area in healthcare has its own culture, and each area believes that the rest of healthcare evolves around their culture, which in fact is not true. And within our cultures, we have to look at how they're comprised, and there can be a difference in the human diversity or the different people we have that make up the culture. The workplace culture can vary from one hospital to another, one facility to another, or one country to another. And patients' interactions can vary from person to person. So there are a lot of ethical decisions that are made based upon our medical imaging workforce. There are many ways of providing health care, and research supports that clinician or disease-centered health care is less effective than a biopsychosocial system. When we're talking about biopsychosocial, we're of course including ethics and what culture is involved in providing the health care that the patient needs. The best practices for patient-centered care revolve around communication, coordination, and cooperation. The benefits of incorporating good communications, coordination, and cooperation within your healthcare practice is that there is a high rate of patient satisfaction, and there's increased adherence to care with improved outcomes. So effective care plus improved outcomes equals effective cost. So being cost effective is the cornerstone to changing healthcare environments. Let's review a flowchart of solving ethical problems. First, we must define the moral problem. Then develop courses of action to address that problem. Determine the preferred course of action from those that we have developed and deploy that course of action. Once the course of action has been deployed, we need to evaluate, did this course of action actually meet the criteria of solving the problem that we were trying to address? Many of the ethical problems we face are based upon cultural differences and philosophical differences, even religious differences. The things that we are trying to do in solving these issues is to have the patient trust us, trust our integrity, how safe we are in their treatment, how loyal we are to treating them, and how responsible we are in taking care of their health. Understanding diversity in culture is one of the many components of creating an ethical approach to patient care. Healthcare professionals play an important role in the care of families from diverse backgrounds. Achieving an improved level of cultural competence will lead to improved communication with the families and reduce disparities in health and healthcare utilization. For instance, if you have a patient coming in from the Middle East who needs a mammogram, often the husband needs to be involved in the decisions or even telling the healthcare worker what the problem is. It is a cultural difference from what we have in the United States. Or we may have different cultures that have a totally different outlook as to what is proper, what is ethical, and what is needed. We are discussing ethics and focusing on how cultural diversity can impact on the medical imaging's professional ability to perform. Remember, the patient has the final word, autonomy. If the patient says no, the answer is no. But different cultures may expect the radiographer or CT specialist or ultrasonographer to perform the exam against the patient's express consent, because it is the family that is considered the decision maker in this healthcare scenario and not the patient. So when we look at patient care, what we'll find is that there are different aspects of patient care that revolve around medical ethics, healthcare culture, and the core cultural values and beliefs of the patient and of the provider of healthcare for that patient. Cultures differ in their understanding of what causes illnesses, how illnesses should be treated, and how illnesses can be prevented. As an example, from my myopic view of Western culture, I certainly would hate to be treated in a culture that decides that whatever happens, happens, and it's a matter of fate, and we'll leave it up to nature, rather than coming in and trying to address my medical problem and fix or cure, not fix, my disease or trauma. So let's take a look at that situation in the reverse. We're very comfortable in Western healthcare practices, but what about somebody that comes from a different culture? The hospital can be disorienting and frightening to people of different cultures. Successful treatment of patients requires that their beliefs, concerns, and what they believe causes the illness and how that illness should be treated and how it can be prevented must be acknowledged in the process of providing health care. To have a good relationship with people from other cultures, we need to learn to listen, respect differences, and remember that our communication style, not the content, may be the problem. For example, think about personal space. We have a personal space in Western culture or the United States where we feel comfortable. In other cultures, the personal space may not be the same. They might want to be closer or farther back. If you're talking to someone who's right up in your face, does it make you feel uncomfortable? Or if you're talking to someone who's very, very distant, does it make you feel uncomfortable? Remember, we're not changing the words, we're just changing the difference. And this is something we need to understand culturally and be respectful of. There are many aspects to culture. Radiologic technologists encounter patients from a variety of racial, ethnic, and socioeconomic backgrounds, as well as from different regional backgrounds or different regional cultures. In a pluralistic society, characterized by many different cultures, the meanings of various behaviors and practices are as diverse as the people demonstrating them. Incorrect assumptions easily lead to miscommunication. We are born into a culture and then learn how to think and behave within it. No matter where you later move to, the culture you were born into and raised in will have a lifelong influence on your values. While it is not possible to know the details about each and every culture that is represented in our workplace or community, we need to know the implications that cultural diversity poses as we provide imaging services. There are three types of communication. There is written communication, visual communication, and spoken communication. Understanding basic communication in all three areas can resolve many conflicts in healthcare. The problem with communication is that people harbor certain beliefs, assumptions, attitudes, and values that cause them to interpret messages as they listen to the words. This may even be within the same culture. Patient communication requires that we interact with the patient, interact with the family and friends of the patient, and use methods of effective communication. Many times the patient will actually communicate to the radiologic technologist doing the exam pertinent information that they have not communicated to their physician or other healthcare providers. The radiologic technologist acts as an agent through observation and communication to obtain pertinent information for the physician to aid in diagnosis and treatment of that patient. The hospital can be disorienting and frightening to people of different cultures. Successful treatment of patients requires that their beliefs concerning the causes of their illness, how the illness should be treated, and how the illness can be prevented in the future must be acknowledged. The following example will demonstrate some of the things that healthcare workers should know while treating patients from different cultures to make the treatment easier, more effective, and communication better. We are stereotyping, but these are basic ideas that come from certain cultures related to healthcare. Let's look at 11 practical points for non-Taoist Chinese providers. What we're looking at here is a specific culture within a culture. The first thing we should look at as healthcare providers is to provide as much family influence and involvement as possible in the patient's healthcare. Second, if needed, you need to be a patient advocate if the possibility of family manipulation shows itself. This is not only in this culture, but you'll always notice, like when someone is about to pass, they're on their deathbed, and most of the family has an agreement as to how they want to end this situation. Someone, a relative from out of nowhere, jumps up and says, no, keep him on life support. I want Grandpa to be around forever. when in fact that person hasn't seen grandpa in 40 years. So what we're talking about here is you need to look at the situation and advocate for the patient, especially if the family is manipulating the situation, because family is all important. Given what we've previously discussed, we still need to recognize that medical decisions are not solely in the hands of the patient and may solely be in the hands of the family. In dealing with terminal patients, you should know that traditional Chinese may be reluctant to discuss advanced directives. You should also understand that most Chinese traditionalists will strongly desire to die at home. Do not marginalize the family. That is extremely important. The family comes first. Don't be surprised because the family really respects family and is there to support the patient if the family does some benevolent deception with terminally ill patients. You'll be okay when you get out of the hospital, that type of thing. If you really want to alienate a traditional Taoist Chinese family, ask about the organ donation on the back of their driver's license. Do not bring up the topic of organ donation. It is a taboo topic within this culture. Also, don't speak of death, as some believe if you speak of death, you may hasten the death. You should not have prejudice also against traditional Chinese medicine. Traditional Chinese medicine is widely practiced in Chinese American communities in the United States. Finally, and the last point is openly discuss mental disorder, disease, and psychiatric services. These are topics that are not talked about within this culture, and they need to be discussed when they are beneficial to the patient's treatment. Have you heard the old axiom, too many soups? Nope, not too many soups. Too many chefs spoil the broth. And this is true in healthcare. Increasing the specialization and the fragmentation within the healthcare community, all of a sudden we've got a lot of people that are having input into a patient's care. And if we have this, there is more potential for miscommunication. With the evolution of technology in healthcare, especially with computerization, although it's rich with potential, the digital health ecosystem presents a new ethical challenge for those that are making decisions. It's being overwhelmed. How much information is out there? What is the right decision? How do you make it? What is your skill level? So again, this is another ethical challenge that we find in healthcare. Evolution and the preponderance of knowledge that we have out there makes it imperative that each healthcare provider participates in continuing education to give them the information necessary to assess the risks and benefits of the healthcare treatment that they are trying to provide. Recent advances in computer science and robotics are rapidly producing computational systems with the ability to perform tasks that were once reserved solely for humans. In fact, in many cases, they perform the tasks much better because each human is unique and each human makes unique choices. Whereas with computational services and systems, it is a standardized methodology of making a decision. Of course, when we use this system correctly, everything's great. But could it evolve into a system that was being misused? Yes, it can. So, however, in the wrong hands, it can be detrimental to utilize artificial intelligence and computational systems for healthcare. We shouldn't forget that artificial intelligence systems are created by humans who can be biased and judgmental. Once again, if you use right, or if you're used by those who strive for social progress, artificial intelligence can become a catalyst for positive change. In working with artificial intelligence, we need to collaborate with the computer science community to try to understand how we can create ethical bounds that can be taught to AI systems. Few medical experts expect AI to completely replace doctors, at least not in the short term. But technology can change how medicine is being practiced daily. We need to take a look at how we can ethically utilize computerization to improve healthcare. In incorporating computerization into the evolving technology of healthcare, we need to be very aware of the 4 pillars of ethics: autonomy, beneficence, malfeasance, and judicial practice. We can use these 4 pillars to help us incorporate how we utilize these systems and how we incorporate ethical choices into medical healthcare. The big question is, do algorithms, robots, and machine learning cross ethical boundaries in healthcare? We need to understand what is big data, what is machine learning, what is artificial intelligence, etc. to even answer this question. Machine learning is being mostly used for decision support, but machine learning is only a portion of artificial intelligence. It is not the whole of artificial intelligence. Can we teach a machine ethical bounds? The answer is no. In terms of teaching machines ethics or adding outward bounds, what we have to look at is the fact that machines are tremendous in finding minuscule facts, recording data, etc., but they do not have the ability to transfer that functionality into reasoning. Machines are terrible at that. Can a machine learn empathy? Will a naturally learning and evolving system teach itself different bounds and hold life sacred? And how will it interpret the challenge of every doctor to do no harm? To teach a machine ethics and intuition is extremely difficult. Teaching inferences and standards within semantics are the first step to teaching a machine intuition or ethics, but this might take forever. Next, we'd have to give the machine a predictive pattern of recognition for each unique individual that they are analyzing the data for. And that would mean giving the machine access to sensitive patient information. The first pillar of knowledge for ethics is autonomy. People have the right to control what happens to their bodies. This principle simply means that an informed, competent adult patient can refuse or accept treatment, drugs, and surgeries according to their wishes. People have the right to control what happens to their bodies because they are free and rational. And these decisions must be respected by everyone, even if those decisions aren't in the best interest of the patient. Years ago, I can remember when I was working in trauma, we had a patient come in that had a heart problem. And the doctor said, well, this is not a big deal. We can just go ahead and get you a pacemaker and you'll be fine. And the patient said, no, if the Lord wants me, the Lord can take me. So they called in the patient's pastor, And they counseled her. She said, no, if the Lord wants me, the Lord is going to take me. They called in the family. They counseled her. And she gave the same answer. No, if the Lord wants me, the Lord is going to take me. Respecting her wishes, we kept her in the hospital until she passed. Beneficence is the second pillar. All healthcare providers must strive to improve their patient's health and to do the most good for the patient in every situation. But what is good for one patient may not be good for another, so each situation should be considered individually. What we're talking about here is it ethical to take a 97-year-old patient who is in failing health and has a DNR to medical imaging to perform a barium enema because the exam was ordered? What are the ethics of this question? Think about it. First, do no harm is the bedrock of medical ethics. In every situation, healthcare providers should avoid causing harm to their patients. You should also be aware of the doctrine of the double effect, where a treatment intended for good unintentionally causes harm. This is where we treat the patient and years later we find out that it causes harm. We're very familiar with this in radiology. They used to treat patients when irradiation first came out for all kinds of diseases. And later on they found that overdosing these patients in these treatment caused the patient long-term effects and harm. Justice. That's the fourth principle of ethics, and it demands you should try to be as fair as possible when offering treatments to patients and allocating scarce resources. If we think back to our recent and current future, all we have to do is look at the COVID-19 crisis and think about the justice in the allocation of resources. Weights and balances. Let's talk about weights and balances, risk versus benefit. And we'll start with teleradiology. Teleradiology is a part of telemedicine, where we can actually provide resources to remote areas without having to physically go to the area. We can do this over the network or the internet in the cloud for transmitting data. The good news is with technology evolving so fast, we really don't have a lot of answers because we don't even know the questions. A lot of it's still unclear. The bad news is we're dealing with lawyers when we're trying to answer these questions, and medical legal questions are issues in teleradiology. How about medical liability? The radiologist or interpreting physician is as liable as any other radiologist in the given setting for technical issues, interpretation and misses, and communications. But how does that relate? Are we going to go to India and have the physician be deported to the United States for a trial? Probably not likely. So again, medical liability is an issue. Unlike staff radiologists, teleradiology companies often aren't able to influence the quality of the images, and what we're talking about here is they have no communication during the process of creating the image with the person that's acquiring the image. Simply, teleradiology is store and forward telemedicine. Store and forward telemedicine requires acquiring medical data like medical images and biosignals, and then transmitting this data to a doctor or medical specialist at a convenient time for assessment offline. It does not require the presence of both parties at the same time. What are the basic requirements for a teleradiology system? As we look at informatics, the basic requirements for a network is basically a computer and the ability to transmit to another receiving computer. The same thing for teleradiology. We're looking at an imaging sending station, transmission of the data, and a receiving imaging station for interpretation of the data. Conceptually, the process is very simple. The imaging data is acquired at one site. It is then transmitted over a network to a server. The data can be stored on the server and interpreted at a remote site at a later date. A report would be generated and transmitted electronically back to the parent site once the interpretation has been done. In committing to a teleradiology system, one of the keys is what radiologists from the sending facility want from their teleradiology service. Well, obviously they want quick turnaround time. They want a very low miss rate. They want qualified and licensed readers, and they want a good quality of care, including customer service, billing, and IT from the teleradiology service. At the receiving end, well, at the receiving end, the radiologist analyzes the image and makes an interpretation based on the clinical information they have received. They do not know if this image has been post-processed or many of the bits of information that would be available to a radiologist on site. The radiologist from the receiving station then communicates their interpretation back to the sending station or another designated site. Well, we talked about certification and licensure earlier. This is where licensure becomes very important. Physicians who provide the official interpretation of images transmitted by teleradiology should maintain licensure as may be required for both the transmitting and receiving sites. In other words, if I'm in New Delhi, I need to have a license to read in New Delhi, but if the images are coming from Des Moines, Iowa, I need to have a license at that facility to read for the Des Moines, Iowa facility. When providing the official interpretation of images from a hospital, the physician should be credentialed and obtain appropriate privileges at that institution. These physicians should consult with their professional liability carrier to ensure coverage in both the sending and receiving sites. Do you think it would be unethical if I was a radiologist and I was billing the patients for the interpretations and I was getting a large sum for each interpretation, but I didn't actually read the images? I had the images sent out where a radiologist read them for pennies on the dollar. Yeah, you bet. The ACR has previously commented on the practice of radiologists signing reports initially read by teleradiologists without reviewing the images. This so-called ghost reading. In response to this, the council has put out some ethical implications, the American Board of Radiology and American College of Radiology, for physicians who do this practice. We had at one time the same problem in the medical center. We have teaching hospitals in the medical center in Houston, and what was happening was the residents were reading all the images and the doctors were getting paid for them. They're supposed to be reviewing the images, but were they? Well, obviously this became a problem, so we know the answer to that one. Anyway, ghost reading is not a good one. Obviously, teleradiology will continue to evolve, and radiology services in the future will be almost completely outsourced because there is little need for a radiologist to be involved in the actual acquisition of the data and the images. After all, more than 90% of conventional X-ray is diagnostic X-ray, MRI, CT, and ultrasound. That leaves less than 10% to be an examination that requires the physician to participate in the examination. Outsourcing radiology services to intelligent, motivated, and well-trained radiologists who can do the work for a tiny fraction of the cost benefits everyone according to macroeconomic principles. Let's harken back to theory and reality. In theory and reality are both the same. In reality, they are not. Currently, we have traditional radiology practices that are associated with hospitals and imaging centers. We can outsource the radiology services to service providers such as teleradiology services. We can use this as a percentage of the total amount of interpretations that we get in our radiology practice. Teleradiology is borderless. So how did we cope with this problem? How are we trying to cope with this problem? Not that we are. Well, several hundred U.S. hospitals use overseas teleradiology services. Industry leaders such as Teleradiology Solutions, Nighthawk Radiology Services, and Virtual Radiologic are companies that adhere to the American College of Radiology guidelines with respect to licensure, insurance, and hospital privileges. Now we look at compensation, and because Medicare and Medicaid, or the federal government here, is one of the largest payers for healthcare services, they have put some boundaries or restrictions on how people are reimbursed. An obstacle that many of the companies finesse by providing a preliminary report, which is later followed by a U.S. radiologist's final report, is that the overseas radiologists are paid directly by the hospital or local radiologists at obviously a lesser rate than the hospital or local radiologist is charging for the services to the patient. For billing, the Center for Medicare and Medicaid Services, CMS, considers the site of service to be the location where the professional service was provided. And Medicare does not allow payment for services that are outsourced to places outside of the United States. For international teleradiology services, Medicare permits payment only if the services are a preliminary interpretation. So once we've got the logistics kind of taken care of, the biggest hurdle is regulatory. And it may be credentialing and licensing requirements. They can often make it difficult to read the studies in the next town, let alone in Australia or India. If someone is going to read, he or she has to be board certified in the United States and have a state medical license in the state in which they are providing services. In addition, that person must have passed all the credentialing requirements of the hospital, and in order to bill for the exam, it has to be interpreted on U.S. soil.